Our next session will discuss the feasibility of the specific strategies, levers, and stakeholder responsibilities discussed over the series to accelerate financing that rewards better health and well-being. We have 3 speakers. I will introduce them all now, and they will present in this order. They'll each have about 15 minutes, and then we will have about 15 minutes of Q&A at the end. First, we have Dr. David Molstein, Chief Strategy and Chief Research Officer for Levitt Partners. David's research and expertise centers on healthcare payment and delivery transformation, understanding healthcare markets, and evaluating how the broader healthcare system is changing. He will be followed by Dr. Vivian Lee. She is President of Health Platforms at Verily Life Sciences. Prior to joining Verily, Dr. Lee served as the Dean of the Medical School and CEO of the University of Utah Healthcare, an integrated health system with a budget of $3.6 billion, including a 1,400-member physician group and health insurance plan. During her tenure, she led University of Utah Health to recognition for its healthcare delivery system innovations that enable higher quality at lower costs and higher patient satisfaction with superior financial performance. And she will be followed by Dr. Donald Berwick, President Emeritus and Senior Fellow at the Institute for Healthcare Improvement. Don almost needs no introduction, as he is recognized globally as a leading authority on healthcare quality and improvement. He's served in numerous leadership and advisory roles for the Institute of Medicine, the U.S. Preventive Services Task Force, the American Hospital Association Board of Trustees, and the National Advisory Council of the Agency for Healthcare Research and Quality, just to name a few. Again, after their 15-minute presentations, we will have a 15-minute Q&A. I turn it over to Dr. Molstein.
Thank you, Keisha, and it's great to be with you all today and to share a few thoughts based on these past few days. And I've greatly enjoyed listening to the different speakers and learning about those, and learning about the different challenges and perspectives that people have. And that's one of the most important things that I get from these sort of conferences, is it's the chance to learn these different perspectives and where people are. What I want to do is zoom out a little bit. Over these past few sessions, we've learned a lot about the issues in healthcare, and we certainly didn't address all of those, but we've also learned about different models and activities and efforts that are underway, and we've learned about many different people that are actively pursuing improvement in the healthcare system. And that's incredibly important, and I'm glad that we've spent time there. But what I want to do is zoom out to looking at it from a macro perspective and talking about where we've been, where we're going, and kind of what is needed to get there. There was somebody wiser than me that said we should start with the end in mind. And to do that, we really need to understand both where we are and what our end might be. So we know that healthcare has become an increasingly large part of the GDP. In 1960, it was about 5% of GDP, and that's grown up to nearly 18% today. So a very significant growth. What's maybe not quite as well known is that government spending on healthcare started at 2% of all government expenditures were on healthcare in that same time frame, the early 1960s, moving to 31% today. And so there's been a much higher, it's been a more dramatic and much larger growth. So if you think of that as a third of all government spending is going toward these healthcare related things. So when we think about what's going on, we need to decide, what do we do with our issue? We know that it's not a sustainable amount of money that we're spending. And in fact, the Medicare Trust Fund is expected to be exhausted in just 2 or 3 years, which is the closest it's ever been to exhaustion. And so we have to decide, how are we going to address it? And the way I look at it is I like to use analogies. And one analogy is you look at a house. You buy a new house that isn't in the best shape. Do you try to repair things? That's just, putting some paint, fixing some dings in the walls. Do you try to remodel? Do you say, let's knock out a few walls and really build something that we want? Or do we say, this house is really a lost cause and we need to scrap everything, tear it down, and build up again? And I think that's what we have to think about with the healthcare system. What do we want to do with it? That goes back to that, what is the end? What is our objective? And I think that we all know that we want better access, better quality, better equity, and many other things related to the healthcare system. I think payment, though, is a critical component of this. And you look at how we've grown over time. In 1980, we spent about 9% of our GDP on healthcare. And by 2010, so 30 years later, we were up to 17%. I think what we need to aspire to is to get back down to that 9 to 10% level. Now, that's hard. There's no policy today that's going to get us there over time, but we can change the time frame. And I would posit that we should plan on a similar time frame. How long it took us to get in that situation is how long we should prepare for to go back. And so if we start thinking about healthcare not as an election cycle issue with policies, but think of it over a generational cycle and say, if we want to spend 10% of our GDP on healthcare by 2050, what are the incremental steps that we need to start taking today to make some of those changes? Now, we know the government is spending a lot on healthcare, and so we say, well, why doesn't it just fix it? This is one of those questions I get at any sort of a family party where people want to talk about healthcare policy. Why don't you just fix it? Well, government has many different constituencies that are incredibly important. Beyond just the patients that they pay for through Medicare and Medicaid, there's also their employers. There are the government contractors, the providers that are paying for the system, many other voters that are out there. And so whenever you try to make changes, you have to recognize that solving one problem, the cost of care, comes at the expense of somebody else. So if somebody else is losing, it's not a net positive. If you're taking money out of the system, somebody's paycheck is dropping. And so the government has major barriers for it. And one of those changes that has happened over the past 20 years is that healthcare has become a major driver of the economy. In fact, it's listed time and again as a major growth center for the industry. Healthcare went from being a relatively modest size in terms of total employment to now being the largest employer in terms of industry in 45 of the states. Obviously, if healthcare is has seen the largest growth of employees and the largest growth in investment, people view that as the cash cow. You don't want to cut that out. You don't want to limit that. And so government has to wrestle with the competing desires of encouraging the economy to grow, while also recognizing that a part of the economy is a major drag on the overall growth of the country. So when we think about what we've talked about, these payment models today, there's been lots of comments around fee-for-service and whether it's really the problem, whether capitation is really the best outcome or the best, it's a panacea. I come on the side that fee-for-service is a major problem. And the reason for that is simply following the incentives. And this is where you get what you pay for. And if you pay for volume, you get volume. But the reason for this, the heart of this, is I think the business model that fee-for-service is built upon. A business model consists of four things. There's a value proposition, key resources, key processes, and then a profit formula. What's really important for the business model of most healthcare systems is this profit formula, where people are incentivized for providing care to their patients. And when you come up with a business model, that becomes a foundation of the entire thing that the business builds around. So everything from our EMR records to our supply chain to our employment and training, they're all built around this underlying business model, the resources, the value proposition, the processes, and this profit formula. And there's lots of different ways that you could construct a business model. I'll use two examples. Apple makes a significant amount of money every time they sell an iPhone. Sony, on the other hand, breaks money or maybe even loses money every time that they sell a PlayStation. Well, if you want to buy an iPhone app, it's going to be a few bucks. If you go and buy a PlayStation game, it's going to be $50 or $60. So they both can be very profitable, but they have different business models, and that leads to different approaches to things. And so the business model that we see in healthcare drives much of what happens. And it turns out that it's really hard for people to move away from a business model. I think of the movie Finding Nemo, and there's the sharks that are trying to stop eating fish. Well, it turns out that it's really hard for sharks to give up eating fish. That's kind of their business model, if you will. You've heard of the phrase that tigers don't change their stripes. Within business, it's really hard to move away from a business model, particularly when you are an organization at scale. And so we have to think about what is the business model and what is the alternative to it. I think of healthcare as most of healthcare, fee-for-service healthcare, as a capacity-focused business model. That is, find what's well reimbursed, build capacity to get those patients, and then build a capacity. This is why we see heart hospitals and ambulatory surgery centers and oncology cancer or treatment centers, because those are what's well reimbursed. The alternative is a needs-based model. This is the idea of population health. You start with the population, you identify the needs of that population, then you try to address those needs at the lowest possible price point. there is a significant difference to how you structure these. Everything from employment and personnel to technology and supply chain, you have to make changes for these. And this is as much of a difference as a fine dining experience to a fast food establishment. Both of those will feed your belly, but they're going to do it in very different ways. And it turns out that it's really hard to change a business model when organizations are doing pretty well. And while healthcare has changed a lot in the past 50 years, most healthcare systems are doing quite well, as evidenced by the rate of growth, new growth in terms of new facilities, new hires, et cetera. And so how can you do it? How can you change your business model? First of all, as long as you're at what I like to think of as the fee-for-service buffet, it's really hard to lose weight. As long as you can always just say, one more patient, one more head in our bed, we're going to do better. You're not going to be able to drive a lot of that change. So when we think of that, we look at all of the activities that are going on, many of these under a fee-for-service system. And there are a lot of really awesome initiatives that are underway with a lot of people doing phenomenal work. And it's incremental. But what they're doing is they're building on a fee-for-service chassis. And the question that I ask is that going to ultimately lead to a tipping point where they can move to these new business models where they're trying to address the needs of the patients? I'm hesitant to believe that that's the case. Instead, I think what we're doing is building, if you go back to your days of calculus, that's what's known as a local maximum. You're building to a certain point and you can't go left or right along the line and get higher. Instead, what you do is you drop back down and you build differently, and then there's a much higher maximum elsewhere. Sometimes it's really hard to know if we are in a maximum or a minimum. But I think that the fee-for-service chassis inherently is going to lead to a local maximum and not the global maximum that we're aspiring to do. But there are organizations, many of them out there like CareMore, Landmark, ChenMed, Oak Street, and others that have a very different business model. They're not worried about all of the different, the same coding issues and the same heads and beds. They're saying, how do we take care of our population? And I certainly don't want to think that they have solved everything and they have all the answers. But what it's a point of is there is a different business model in place. Another question is, that we think about this long-term transformation, is who needs to be involved with this? And I wonder, we have a lot of people that are incredibly established and have done much good within the world of healthcare, but there are also many of them operating under this model. When we think of the largest organizations that exist, they have a strong incentive to maintain their business model and continue what they do. At the end of a long war, for example, World War II, who is the best person to transition you into peace? Is it the generals that led the war, or is it someone else? I think it's an open question. I think that there are certainly people that can make that transition, but there might be others that really aren't in a good position to be able to move away from that fee-for-service mindset. So how do you make the transition? And does it come from within or without? If you're operating today in a health system and you say, I see the future and it's better for my patients and I want to move towards a value-based focus, you commit to it, you try to transform your organization slowly but surely, day at a time, and make lots of incremental changes, making sure that you bring the physicians on board, the board of directors, your community, and you make all of these sorts of changes. And you have to do it under the same time frame that you're foregoing potential revenue. It's hard. I'm not saying that it can't be done, but it's difficult, and it requires continuity of leadership. The other approach is when there's external changes. And frankly, when somebody is coming and beating you at your own game, there's somebody that has a different business model and is coming in and competing and you're not able to, and that forces you to change your business model. Use one example of that. 10 years ago, Garmin sold GPS machines. That's how they built their business. Well, then Google came along and started giving away Google Maps for free using the GPS that was on people's smartphones. Garmin had to make a major pivot because there was no longer business to sell this GPS software that they had. If there is an outside force that's driving it, I think it's going to make things happen faster. So when can you make the change for an organization if you're a large health system or someone else? I think that the obvious time is when there is a crisis. It's not when times are good. This is Rahm Emanuel says, never let a good crisis go to waste. Identify what changes need to be made at the time of a crisis so that you're ready to implement them. It's not saying that we should go and drive a crisis in healthcare, but they will come. And when they do, be ready to make those changes. So when I look at things today, I say, should we repair, remodel, or rebuild our healthcare system? And I think we really, with that 30-year time horizon, need to do all three. Today, we need to focus on what's repairable and quickly fixable. We need to remodel things to what's good enough over the long term, but in the midterm, in the long term, in the coming decades, in the coming generations, we need to build a new system that actually generates what we want. This goes back to the idea that you get to what you pay for, and what we ultimately want is health. And so as long as we're focused on paying for health or for care, that's what we're going to get. We need to come to models and to a system that's paying for health, not for the care. So how do we do that? I have a few policy proposals. The first one is certainly move forward with mandatory models. This is even if people aren't changing their business model, they're getting experience in value-based models that prepare them so that if there is a time that they have to change their entire business model, they're better positioned to do it. Another one is that we need to move beyond 12-month contracting periods. You can't say that you've successfully managed a population in 12 months. We need longer-term time horizons. And we need to provide incentives to business models that are not built on fee-for-service. And that could be tax benefits or other things or special contracts through Medicare, but are focused on the people that are not on a fee-for-service chassis. In the intermediate time, we need to set a goal. We need to come to agreement. Do we really, as a country, want to move towards 10% of our spending of GDP by 2050? If so, we need to be able to come to some sort of a, maybe not consensus, but groups that believe in this. We need to track that and monitor it and make sure that we're holding ourselves accountable to that. And we also need to figure out how we actually pay for health instead of paying for health care. And in the long term, the most important thing is that we need to have patience. We would love to change everything in a calendar year or an election cycle, but to change healthcare, we need to be committed to a generational shift. And that means that we need to link arms, and not for a few days, but for a few decades, to figure out how we're going to improve healthcare. And with that, I will turn it over to Vivian.
Great. Thank you so much, David. And it's your words are really resonating with me because one of the people that I talked with just when I was trying to come up with the name for my book was Mike Levitt, Governor Levitt, who said, this is a long process. This is going to take some time. And that's exactly how I ended up with a title called The Long Fix, was exactly the words you were saying. Although I think we might all agree that with COVID, I think we've seen the crisis that you alluded to and the opportunity to really accelerate some of this change, all the points that you raised. So thanks everybody for the chance to join today's session. I feel really proud to be a member of the National Academy when events like this are being sponsored, and so many of the themes that I heard today and from the notes that the team was able to share with me from last week really resonated with me. You know, the role of patients, the role of communities, how do we think about new payment models, addressing equity and disparities. And I think we all have heard, and David laid out very nicely in his opening remarks about this inflection point that we're at now and the critical need right now to address, I think, the issue that will define our generation's legacy. Are we going to actually finally change the direction of how our healthcare system is going? Actually, the answer has to be yes. We have to change it, really. There is no alternative. And from whatever our perspective is in terms of the issues that we're looking at, I think we all see this Gordian knot. It's a paradox. How can we spend so much money and yet have poor health outcomes and such widely disparate outcomes? And the perspective that I'm going to bring in these few minutes of comments that I have is really one that mirrors my own experiences, starting in academic medicine, starting from a research background. And over time, when I was at NYU, coming to the realization that it was really less about the research shortcomings than more about our ability to translate what we already know works into the hands of people and communities. And so that's what led me to the University of Utah, to David's backyard there, to that integrated healthcare system with a very large rural population. And then more recently, I joined Verily, which is Alphabet's healthcare company, about 3 years ago to build health platforms. And so we're now a family of about 5 or 6 businesses. And so it's from those vantage points that I wanted to talk a little bit more about the role of technology and data, and specifically to put the discussions that we've been having in the context of this idea of co-producing health. And this is an idea that I did not create. I'm really building on a rich foundation of thought that precedes me, starting with Victor Fuchs, the economist that now at Stanford, and then the Bataldens, for example, who have written very cogently about this. And it really, I guess if we take a step back, I think we all understand, and David just alluded to, that the secret of a better healthcare system, the secret to lowering costs, which we're all pretty obsessed with right now, is simply better health. And when we think about how we talk about better health in medical school, for example, when I was the dean, we have this standard slide, reminds everyone that of the determinants of health, the clinical piece, maybe around 20%, roughly speaking, individual health behaviors, maybe 30%, social and economic factors, maybe 40%, give or take. And so we have focused so much of the narrative on what happens in the clinics because that is really where the enormous growth and cost has happened. It's where the profit opportunities have been the most obvious. But of course, it's not, as we've talked about at this session and in other venues, they're not where the greatest levers are. So that's where it comes back to this idea of how do we really engage patients, which we were talking about in the previous session. And Victor Fuchs wrote about this in the 60s, this idea that the US economy was moving from a manufacturing economy to more of a service economy. And as we move from manufacturing to a service economy, and I would argue most of healthcare is a service economy, we're really much more about how we actually engage with our customers, in this case, our patients, in co-producing that service. I think the Bataldens called it moving from consumer to prosumer. So simple example would be in banking. So banking has made that evolution. We used to rely on our tellers. We'd have to go into the bank just to figure out how much was in our accounts, how to deposit money. And nowadays, of course, we do everything online. And with fintech, we can even get a loan, within 5 minutes. And so if we think about healthcare or health tech, what would it look like if we all were prosumers of health? And the realization I think that I've come to now, having moved from academic medicine into Verily, a technology company, is just the tremendous opportunities that the digital health space offers in terms of making that leap into a co-production mindset. So I'll just, for example, drop 3 quick examples of some digital health products that are out there. One is one of my favorites. It's called Pivot. It's a company that was started by one of my classmates from medical school. He's a head and neck cancer doctor. I think it was at Stanford, and he just got so fed up with the tragedies of caring for people, with head and neck cancers that he thought were totally preventable. So he started Pivot as a smoking cessation program. It's a digital health solution. It has a little carbon monoxide monitor that the individual blows into, and it gives you a red, yellow, green scale to show you how much carbon monoxide is in your blood. So there's a little bit of personal feedback. And then there's the app with a lot of programs, a lot of engaging initiatives and actions that you can take, and gives you really good feedback. And then over time, challenges you, for example, to stop smoking for a day and then extend those periods. That's one example of a digital health solution, really thinking about co-producing health, because obviously it's the individual, mostly the responsibility of the individual to stop smoking. Another example that I know very well is one that is a part of our company, Onduo. It's a hypertension, diabetes, weight loss, mental well-being kind of digital health app, a lot like a lot of others in the landscape. And again, here, for example, if you're looking at blood pressure, there's a blood pressure cuff. If you're looking at diabetes, there's a blood sugar, blood glucose monitor that gives you that personalized feedback. And then there's the app where you can either take pictures of your meals and snacks. You can have some AI recommendations that makes observations about your diet. It's very personalized to you and your own habits and your own experience. And then there's a telehealth component, again, with a coach or with a clinician to provide that human feedback. So there's Pivot, there's Onduo, and then there's the third one I was going to mention was Thrive. So this is Arianna Huffington's company, and this is again a digital platform. It's more about wellness overall. A big factors around social well-being, Again, offered by the employers, a way for individuals to focus on the things that really matter to them, and then kind of micro nudges in terms of behavioral changes. So in all of these, you sort of start to see a common theme where there is the idea of collecting some information, collecting new information in many cases about individuals. This is, I think Dina made the point about how healthcare tends to be starting with everybody, sort of a one size fits all. And I think some of these approaches pushes us into a more individualistic experience. And then so after you collect some information, you organize it and you really try to make it actionable. And doing that in the context of the home environment where people can focus on what matters to them and really co-produce their health. So what are some of the actions that are necessary for this digital health space to really fulfill its potential of co-producing health? Well, I think one, digital health companies need to be held to a higher standard of truly generating evidence. We need to see real evidence that these products work. We need to make sure that the payment models for digital health solutions don't simply recapitulate the same shortcomings of traditional healthcare. So how can those payment models reflect a value-driven agenda? Instead of paying for every time you click on an app, how do we make sure that these programs, for example, are compensated based on their ability to reduce blood pressure, to have sufficient engagement of diverse populations, not just the worried well? How do we make sure that they really improve health outcomes, and how can we have the payment models reflect that? So that's the second. So the first one is generate evidence. The second one is the payment models to reflect the value-driven agenda. And then the third is to really make sure that they don't become more siloed, and that there really is a direct connection between these digital solutions and, say, EHRs or other, sort of established data sets. Right now, there's so much proliferation in the digital health space. We're not just talking about creating a handful of new silos. This would be like millions of silos. So this is really a chance right now in this very early phase to ensure that the digital data gets integrated into the EHR data and back and forth. So those are three actions that I think are necessary for that co-production. And then I will finish my remarks by also saying that in this framework of co-production, there's a really critical role that clinicians should be playing in the co-production. And I feel that we are really, while there's a lot of focus on new payment models, I don't think we're thinking enough about how to engage clinicians and other, people in hospitals and traditional healthcare systems in the process in a way that is going to lead to success. So whether it is a pay for performance or a capitation or a global budget, the systems themselves need the tools to know that they can be successful. And you may react cynically about that, but I will say that as somebody who used to be in that seat, I believed in value-based care. On the other hand, I did not want to be the first CEO to bankrupt the University of Utah Healthcare. So I needed tools that enabled me to see for every episode of care, the outcomes and the costs of care for every patient. So that if I was to engage in a bundle payment pilot project, which is what was up at that time, and if I wanted to be hold everyone accountable for better health outcomes, as well as the cost of care, that we actually had the data. And that was not available at the time. We had to build our own system. It actually led to a lot of success by reducing the cost of care. We more than doubled our margin. There are many companies now that have productized this. We are also building, we've built this also at Verily. It won't be surprising to you. It is a product that I think all systems need, or they can either buy it or they can build it themselves. I'm agnostic to that for the purposes of this conversation. But I would say that for any new payment model we want to implement, we need to, in my view, attach that to a requirement that there is some built out of the infrastructure that is necessary for those systems to succeed. Otherwise, the temptation to work around those, to to come up with alternative approaches to retain revenue are going to just simply be too great, and we will continue to see the gaming of the system. So for this piece, for the co-production of really engaging clinicians and really engaging health systems, I think we need to see that we have accurate risk-adjusted models, the ability for each of the systems to actually measure their costs of care, and to ensure that the systems themselves are also incentivized to make those digital connections with their patients. So not only should the patients be asking for their digital health to come in and out, but the health systems should be expected to make those data available back and forth so that they can enable their patients to co-produce health more effectively. So those are a few ideas about co-producing health, both from the perspective of the patient as well as the clinician and healthcare system, and hopefully some of the opportunities that the digital health solutions can bring forward. So with that, I'm very glad to pass it over now to Don Berwick.
Thanks so much, Vivian. Let me just check that you can hear me okay. Is my audio working?
Yes, we can.
Great, thanks. Well, this is really redundant after David's brilliant remarks and Vivian's brilliant remarks in her terrific book. I'm not sure I have anything to add, but I'll try to give you some summary conclusions from what I've seen in these workshops. The workshops have been very rich. My thanks and admiration to Mike McGinnis and his team. Mike, you're always raising our eyes to what's important, and I really appreciate your national leadership. This workshop's been full of ideas, full of very thrilling examples, really wise counsel. Overall, though, I think I want to go back to basics in my final chance to share thoughts with you. First of all, I think the concept of value-based payment and these reforms, we're wandering. What strikes one through these 3 days is the complexity of how many dials are being spun, how many things are being tried, and panoply of very important detailed models of the delivery system in. But I think value-based purchasing and the payment system, we need to stare it in the face and say we're really pretty confused right now, and I think we are. I want to go back to a chartering notion that has been on my mind for many years. I'm going to share my screen, which I think might be illegal in this meeting, but I'll do it anyway. So this little diagram has been one of my kind of reference points for several decades in my career. I drew this first during the authorship with the committee that wrote Crossing the Quality Chasm. And it just wants to make a simple point, although it's a complex diagram. When we're talking about what I'll call environmental designs, like financing, for example, or regulation or accreditation or education or in policy in general, it's really important to get what I call the chain of effect clear in one's mind. Everything in improvement begins with aims, and we've got to look first to the aims. Like, what are we really trying to accomplish? When I drew this diagram, at that point was relevant was the Institute of Medicine's 6 aims for improvement: safe, effective, patient-centered, timely, efficient, equitable change. That's been trumped to some extent by, I hope, the triple aim, which is to realize that just working on care, as many of the people that commented on in this meeting have said, isn't enough. We have to work on generators of population health and also per capita cost, the triple aim, which was my charter when I ran Medicare and Medicaid. The experience of care, the well-being of the community is produced by microsystems, by processes that affect patients, clinics, physician visits, surgical theaters, web page designs. That's where the care meets the need. These microsystems are supported by an organization. It could be a hospital, could be a group practice, could be some integrated healthcare system. And then all of this bathes in the environmental context, where we do things like decide how to pay, decide how to regulate, decide how to accredit or educate, or what policies to make. When we begin with the environment, we make a tremendous mistake. Everything should start here. Everything starts with the aims we're trying to produce in the communities, and all proposals for change in anything, microsystems, organizations, or most importantly, finance, delivery, regulation, policy, need to be interrogated in view of the aims we have, interrogated hard. There's nothing noble or biblical about any design concept at the environmental level. All purpose, all nobility, all meaning, all heart lies in the experience of the people we're trying to help, the communities and families, and in the processes that directly interface them. So I always say we need to interrogate ideas for change, including financing change in terms of the goals, the triple aim. So let me get a little more granular about aims. And David Muhlstein did a brilliant job discussing this just a few minutes ago. So a lot of this may echo in what David said, I hope. Here is maybe sort of a initial list of things we're trying to get done. Get everybody covered, leave nobody out. We have a national embarrassment not having healthcare be a human right in this country. That's got to stop. Reduce costs. David ambitiously wants 10% of GDP by 2050. I would aim for 15% of GDP without any rationing of care within the next 5 years, 10 years, 8 years. I will point out, and I think we have to be brutally honest, a decrease in the rate of rise of cost is not a decrease in cost. And all this conversation about financing and value has allowed us to escape the discipline of understanding this country should be spending less per capita on healthcare by far. Other countries, as you know, get much better results at a much lower percent of GDP. A third aim I would have was, since we're going to do this without rationing, is to really target waste in every form we have. And there is waste everywhere in our system. Games played around coding and risk adjustment, transaction costs and high administrative complexity, overuse of unnecessary care driven by a fee-for-service legacy, undisciplined pricing, confiscatory pricing. I would say pricing that approaches morally unacceptable pricing, and out of control measurement, which adds burden everywhere in our system without any goal. Remember, the ideal medical loss ratio in American healthcare is 100%. We need to focus on what matters to patients and families, as Vivian was talking about so eloquently, was written about in her book. As this whole conference is focused on, we need to shift resources to the real causes of illness, injury, and disability, the social and societal determinants, including structural racism, but not confined to that. We need to put the most vulnerable first. Sick people are poorer and poor people are sicker. And so if we're going to help improve health and our well-being in our country, we're going to have to shift resources toward people who are vulnerable and of lower income. That's not a moral statement, that's a logical one. We need to end health inequity, just target it and stop it. We need to improve patient journeys over lifetimes. The event-based, transaction-based view of care misunderstands what matters to most people throughout their lives, especially as we enter an era of aging and chronic illness even more. We need to help foster, restore joy in work. Whatever we do that demoralizes the healthcare workforce it doesn't make any sense. Not if we're after health and well-being. You can't get health and well-being from a workforce that doesn't feel itself healthy and well. We need to foster continuous learning and improvement. We need to be a learning nation, as we talk about learning organizations, as the National Academy has written about so eloquently. And we need to end reliance on hospitals. The hospital needs to become not the center of American healthcare. Home needs to be the center, as Vivian has been talking about. If you interrogate our payment system, as David said better than I'm saying it, it fails. It fails. For almost all of these particular aims I've listed, one would not logically expect fee-for-service medicine, fee-for-service payment to deliver on any of them. There's nothing on this list that when I ask, will fee-for-service help, the answer is clearly yes. I can't find one. Value-based payment as currently played out also, it's a non-starter. It can't help. The dimensions of commitment, of social commitment and investment that would lead us to universality or cost reduction to 15 or 10% to make MLRs 100%, overall lie outside the boundaries of what currently is meant by value-based payment. I think mostly when people say value-based payment, they're using it as a trick, as a way to get more money, a different way, instead of being more disciplined about actually getting to what matters to people. The three areas that value-based payment might help the way it's playing out is what matters. If we were to make value conform to what patients and families say about their care, I suppose. We put that in the metric set. Value-based payment, if the boundaries are wide enough in time, should help us improve patient journeys as opposed to fee-for-service, so that really hasn't happened very much. And there's nothing particular about value-based payment that would decrease reliance on hospitals unless we configure, again, the value-based payment pot, to look far beyond the boundaries of hospitals when the payment is there. So those are possible. But for the others, I think this is more a matter of larger issues of social policy and finance and I'd say moral commitment in the nation than to the turning the dials on a value-based payment system as currently designed. There are no ratios in value-based payment that's going to achieve the aims we have. We really need to do something bolder and more. I guess I'm more on the big redesign side than as David seems to be. If we're going to act now, what would I conclude if we want to aim there with the environment and the organizational designs? I think we have to get to global budgets. I just can't think of, I guess, a shorter road to success on the real aims for health and well-being than to fund organizations to take care of populations with global budgets with extreme discipline that is no more than this amount of money, but extreme flexibility. Use the money any way that you think could help. We are a very heterogeneous nation, and I think that we need to have policies that allow the fastest to go fast. I think we need to unleash whatever tastes exist in the country now to go to global budgets and true responsibility for well-being of populations. We've got to stop the risk adjustment factor coding game. It is a thief. It's not illegal. We set it up that way, but literally, depending on whose research you read, say Rick Carnick's recent writing, we are looking at 100 or hundreds of billions of dollars being siphoned off from no value at all just by adjusting codes, and it's got to stop. It really offends the social need. And we need to reduce transaction costs. MLR should be 100%. And that means that people that make their money right now on MLRs of 80 are in the wrong business. And I know we can't get to 100, but we could sure get closer. That means, to me, reducing financial intermediation. We have interposed between patients and caregivers, between payers and caregivers, layers of non-value-added financial manipulation that just hurt us. And I think we need to stop it. I'm not politically naive enough to think we will. The lobbying is phenomenally powerful, but financial interests intermediating between payers and patients and providers do not add value. At least they haven't shown themselves to do so yet. I think that, as Liz Fowler mentioned, I think empanelment is key. I don't know if it's possible in a heterogeneous nation, but the closer we can get to people having empanelment in primary care settings, the more we'll be able to move to rational global budgeting and real plans for health support. That does require an integrator. It's not a soloist job anymore to help people navigate through the care system. And so some level of organization that integrates the flow of care, not as a financial intermediary, but as a healthcare management intermediary, is an important part of the redesign of our system. The measurements need to reflect the aims. And so the triple aim and universality, which would be 4 basic metrics. Is everyone covered? Is quality continually improving? Are social determinants being improved? And are we reducing costs toward, let's take the Muhlstein goal if you want to be more ambitious. That's how we should measure success. And I don't know if the panoply of measures we develop really help us move in that direction. I guess I'm arguing for big change and a little bit of a restart here, because I think financial reforms have become captive still of the status quo, and that's not going to get us to the goals that we're talking about. I'll stop there and appreciate the chance to share thoughts and look forward to some questions and responses.
Thank you, everyone. I invite folks who are listening in to put questions in the chat. We have a couple to start. You know, one of the themes that has come up earlier in the series was, we keep going back to the same stones, and we're bleeding the same stones for finances. And how do we start to think about, there's consistency that we need money in the system in a different way. And what are those new stones that we need to start bleeding and overturning to really help finance things in the right way?
David, you're muted.
I'll jump in with being unmuted. So I think it's a really good question. And I think that there are a lot of those. And I think that's one of the challenges, is that most of improvement in healthcare, there's not one thing you do, it's 100 different things that you can look toward. I'll mention two that I think are very plausible. So one of those is starting to do a better assessment of how addressing social determinants of health really do impact broad stakeholders within a community. So oftentimes you want to say, how is it impacting a single payer or a single health system, and you try to put an ROI on top of it. But the reality is when you improve the social determinants of health, it has implications for a much broader swath of the community, everything from the police department to the schools to nursing facilities. And when you start to look at it in the aggregate, you can see that there's a real ROI for those. You have to quantify that. You have to balance where it does apply and where it doesn't. But I think you can look at seeing the benefit of addressing these as much greater than just the healthcare system. The second one is following the money and identifying where we feel we are spending too much and seeing how we can limit that. There's a great example of this. Medicare, even before Dawn's time, said we are going to reduce our spending on imaging. And you can see that when Medicare made an aggressive push to lower how much imaging was being done, very quickly you saw a reduction in the total imaging expenses and how often it was being used. And so let's take an honest assessment of where those high costs are and say, we're actually going to take money out of those pieces of the pie just because they're too big.
I'll say, Keisha, a couple of other thoughts. David, there's always stuff I wish I thought to say, but for a particular segment of the population, people under enormous social stress, if you look at what government is spending on them through many different channels, it's usually a very large amount of money per person. It doesn't have to be just in the healthcare system. And so if focusing the ability to consolidate resources to help people who are under tremendous social and economic stress actually saves money. It's a way to print money, because if you got those monies assembled, you have plenty to put into more rational ways to integrate their care. I think that's well shown. That's not a complete answer to your question. Another thought I have is whether this is, and we had a seminar in the last session number 2, and the workshop dealt with it. Is it time for states? Is there a way to think about a state level consolidated payment that would actually do that would get rid of those transaction costs, move money to what matters, to be able to be more flexible with David's argument, to put the money where the health lies? I think we might be on the threshold of that if we can get enough license from Congress and enough ambition at the state level.
I agree with everything that David and Don have said, and they're always so eloquent. It's always hard to follow them. But I feel like the piece, one area that really is not fully realized is the role of the person as a patient. And so much of our discussions around payment reform are focused on the provider systems. And yet, so for example, let's just take a very concrete example of a patient who is going to come in for a surgical procedure. So of course, what the surgeon does in the operating room is very important, what the anesthesiologist, all those things are important. But equally important, if not even more so, is the preparation that the patient might undergo preoperatively. Their mental well-being, their mental preparedness for the procedure, if they need to maybe stop smoking or lose some weight, or even just simply, do they have a flight of stairs in the home, and is there somebody to help them when they get discharged back? We don't have very good systems right now because it just hasn't been the focus of ensuring that we're engaging that patient, understanding what their needs are before they come in for a procedure, And then when they go home, are they well equipped in the home environment? Do they understand what the post-operative instructions were? Or like most people, were they handed a stack of papers when they just emerged and, you know, it's all kind of a blur? How do they actually have, if they have questions, how do they get answers to those questions? Are they in multiple different languages? Are they really accessible to everybody in the ways that they need to understand that information? So I would say that that is maybe a stone that is a little bit unturned so far, certainly not reflected in our payment models at all, I think, or very little, and a huge, huge opportunity for really driving down cost, improving outcomes, and it's a huge opportunity for us.
You know, Vivian, I think that's a great point, and I actually want to stay here with you for a little bit to talk about some of the opportunities for technology to address some of that. And so, you know, when we think about digital tools, how do we connect them up to human beings, you know, in the primary care setting, and making sure that we're using technology to enhance relationships and not worsen digital divides? And, you know, thoughts on that. And I also, you know, after Vivian, welcome, you know, David and Donna, if you have comments on that as well, how we continue to use that as a way to build progress.
Right. Well, of course, I'm extremely biased in this, but this is why I made the leap into technology, because I think there's a really tremendous amount of opportunity here. One observation that I make and that I share with people when we discuss this issue of health disparities and whether technology will widen those or narrow those, you know, what the impact could be, is the observation that technology companies, for the most part, do not run health delivery systems. That in order to build products in healthcare, whether it's the smoking cessation product or a product around diabetes or hypertension or mental well-being, they're all done in partnership with community entities or with healthcare systems or with medical groups, or, you know, they're done in partnership because we don't run health systems ourselves. So we don't have access to patients in a regular way. So it's actually really important for us. So from within, what I articulate in the company and what we're working on hard is to ensure that our partners reflect the broader society that we're trying to serve. And similarly, I would say we're not different. I think there's a pretty high density of companies like us in the Silicon Valley area that, you know, recognize that partnerships need to be really made across the country and even across the world, depending on what our ambitions are. So I think that's one really important factor to recognize, that all the technology companies are looking for these kind of partnerships. And if you're in one of those systems, or you're trying to figure out how to ensure that the products are built the right way, facilitating those marriages is actually, I think, a really important step to doing that. And if we can do that, I think that the other piece that often we talk about is access to smartphones or access to the internet. And we're finding actually that that's less of a barrier than most people think. It is still a barrier, but it's less of a barrier. The bigger barriers are cultural differences, are comfort level, are the ways in which these products are actually built. And there, actually, I have a lot of optimism, because I feel that the consumer technology sector, you know, these folks that I work with who used to be in Google Play Store or in YouTube, they have built products that meet a lot of people's needs. I mean, they're very, you know, they kind of can connect to people, and the same phone that we all carry around can really be a very, very different experience for each of us. And that's what we need in healthcare, right? We need kind of a similar infrastructure and set of tools, but they can lead to a very different, very personal feeling, you know, very personalized experience. And I think that's probably the real opportunity is there.
Thanks.
I would just add, I think what I've seen of digital innovation in the past few years is very, very exciting. The ECHO project, Project ECHO out of the University of New Mexico with Sanjeev Arora, is just extraordinary in how efficiently it can reach very high tech support out to very remote and otherwise difficult areas, including around the world. The launch project from the Federal Communications Commission and the National Cancer Institute and the University of Kentucky, trying to get world-class cancer care to rural Kentucky, is just thrilling, breaking down all sorts of barriers to access. So I think there's a lot of potential. I think if we do it right, it'll force us to really rethink finance and regulation at a much more fundamental level than we're doing now. Right now, we're trying to figure out how to code a virtual visit. That's like trying to figure out, how, it's like treating a car like a horse. It's the wrong way to think. We have a licensure and professional licensure that stands firmly in the way of full maximization of the benefits of digital care across boundaries, across localities. So we've got some thinking to do, but I'm pretty excited, more than I am frightened about the digital divide. I think we're going to be smart enough to cross that.
Yeah, certainly many of these barriers that we've put in place that are often unnecessary. Well, we've got about five minutes left, and I have one question, and then I'll let you all give a closing statement if you'd like. And this is one around bringing the patient back into the conversation. And through this whole time, we've been talking about patients and what's best for them, but how do we really bring them into the conversation as we are, collaborating and doing what we think is in their best interest, but really making sure that they remain at the center of the care and the system that we are trying to improve upon?
I'll start with that, and it actually leverages some of the technology question. And I think a lot of what makes technology useful is when it really makes people's lives simpler. And there's often a disconnect, I think, between what people are saying. So on one side, people know that an activated patient tends to have better outcomes. But then when you ask a patient, what does it mean to be activated? Does that mean that you are involved with decision-making, or that you are weighing yourself 6 times a day and doing all of these things that you just seem as kind of useless? And I think that's where the disconnect is we have to take time to understand what patients really want and then help them achieve their goals in the way that they want to do that. And that's what technology has done in many cases. I mean, you go to Amazon and you can accidentally buy something very easily. You could never have accidentally driven to the grocery store and bought something. But you can do that now. You can accidentally buy, a T-bone that shows up at your house. And so you have to understand what they want and don't try to change their minds, but instead say, we want to understand you and we want to make it easier. And if your desire is this, great, we're going to help you to there. But if your desire is over here, we're going to help you over there. And I think that's the challenge, is that we spend a lot of time trying to teach patients to want what the health system wants, as opposed to taking the time to understand what they truly want.
I'd say it's all about power, and patients need power. The more control we give people, the wiser the choices our society will make. And we've reversed the power structure right now, so the patient remains silent and the system tells them what to do. And we need exactly the opposite, and that'll be a much higher functioning system.
And maybe I think I will just restate in a slightly different way, but basically the same idea that David said, which is I think that it's really about making the right thing the easy thing to do. And making the right thing the easy thing to do for people as patients is something that we can do in our healthcare systems ourselves. It's something that I think the digital sector particularly understands well, certainly better than we do in medicine. But it's also, it's to make the right thing the easy thing to do for patients, but also to make the right thing the easy thing to do for doctors and other clinicians. I think that's actually really, really important. And it's critical to achieving, it's one of those stones that you talked about being uncovered or turned over, is the notion that we really, if we have the right tools, then we can actually engage physicians instead of behaving in ways that Don has lamented, in really instead driving more to value, being part of the team in driving to value rather than the resistance. I think that's really important too.
Well, and as we wrap up, I'll give you each the opportunity to make a closing comment if you'd like. I will go in the order that she presented, David, and then Vivian, and then Don.
I'll just reiterate what I said at the conclusion of my remarks, is we need to have a goal and we need to be patient. This isn't something that we're going to change overnight, and we're not going to change it over the next 10 years. But if we are patient, we are going to get to the healthcare system and the health system that we aspire to.
we need to do exactly that and think about the tools that are available to us to achieve those goals in the longer term, or maybe even accelerate that change. And some of those tools are going to be important for engaging patients and for engaging clinicians and other provider systems, so that, as I just said, the right thing can be the easy thing to do, both in terms of achieving better health and co-producing health and running their businesses more effectively in a value-driven world.
I think we need to touch base with, not with values. What kind of nation do we want to be? What kind of community we want? How healthy would we like to be? And I think that conversation needs badly to be had in the open. And I think we're going to find that we have a lot of possibilities we've not exploited. I think the part I can't solve right now is the power of the incumbents. The incumbencies are moneyed, very wealthy, very connected, and they prefer the status quo. And I just don't know how to change that dynamic, but I know that's the problem we need to solve. So at some point, we're going to have to get disruptive, and I'll look forward to that journey.
Thank you all. I think that's a great way to end. Get disruptive.